The management of subretinal bleed involving the macula includes pneumatic displacement of the blood by intravitreal injection of C3F8 gas. This may be combined with intravitreal tissue plasminogen activator for dissolution of the clot. Anti-VEGF agents are also supplemented if the bleed is secondary to choroidal neovascular membrane or polypoidal choroidal vasculopathy. This is an effective therapy for small submacular hemorrhages, but for larger hemorrhages, vitrectomy along with subretinal injection of tissue plasminogen activator is required. TPA causes clot lysis within 15 to 30 minutes. Following this, the blood is aspirated through a small retinotomy or isoexpansile gas is injected into vitreous cavity, and displacement of blood is achieved by prone positioning of the patient. The prognosis in such cases is usually poor and results are unpredictable. Subretinal heme is toxic to underlying RPE and its displacement or removal is essential for visual recovery within 1 to 3 days. In this video, we will present an innovative technique of drainage of submacular hemorrhage. A 43-year-old female presented to us with an inferior 180-degree giant retinal tear and a large submacular hemorrhage. Vitreoretinal surgery was performed for management of the giant retinal tear and the subretinal bleed was drained by a novel technique. Induction of posterior vitreous detachment was difficult due to firm adhesions to underlying retina and presence of vitreous schisis. An ILM forceps was used to create an opening in the posterior hyaloid face, and completion of posterior vitreous detachment was achieved by active suction with a 25G cutter. Vitrectomy was completed, especially along the edges of the giant retinal tear. A retinotomy was created at the inferior edge of the submacular hemorrhage, but drainage was unsuccessful. A second retinotomy was made at the superior edge of the bleed, but the blood was moving away from the backflush tip rather than getting aspirated. Seeing no hope, I decided to go ahead with a weird idea at that moment. And to my surprise, the blood started flushing out of the inferior retinotomy when I injected balanced salt solution through the superior retinotomy, as can be seen in the video. Near complete drainage of the submacular hemorrhage is possible with this technique. This was followed by flattening of the giant retinal tear by PFCL, 3-4 rows of endolaser and C3F8 gas tamponade. A choroidal rupture was observed adjacent to disc intraoperatively. The patient attained a final visual acuity of 20 by 120. Using this technique of two retinotomies, the hemorrhage was successfully flushed out through the lower retinotomy when saline was pushed through the superior retinotomy. To conclude with this technique, we may drain large submacular hemorrhages secondary to choroidal neovascular membranes or polypoidal choroidal vasculopathy, RPE detachments, submacular hemorrhages due to scleral perforation during buckling, or break formation during vitrectomy and trauma. Thank you for your kind attention.